We would like to welcome everybody to today's webinar on ABO-incompatible or ABOi pediatric heart transplantation. My name is Joseph Hillenberg, and I am the father of a heart transplant recipient. My son received an incompatible heart 11 years ago at what is now Ann and Robert H. Lurie Children's Hospital in Chicago. I am the strategy advisor for Transplant Families and have served in board or advisory roles for OPTN-UNOS, Donate Life America, the American Society of Transplantation, the Pediatric Heart Transplant Society, Action Learning Network, and many other organizations related to heart failure and organ transplantation. The first half of our session will be focused on the history, science, and practice of ABO-incompatible heart transplantation. This will be intended for parents whose child has received or may receive a heart transplant, regardless of the country that they reside in. We will follow that with a discussion of a proposed OPTN-UNOS policy that, if approved, would allow for more widespread use of hearts and lungs in children in the United States. Our intent here is to inform both parents and providers of the proposed changes and mention some points of the policy you may wish to note. OPTN-UNOS public comment has recently begun, which is a time period twice a year when the transplant public is invited to share their thoughts on various changes to the U.S. transplantation system. Based on that feedback, the OPTN Heart Committee may incorporate that feedback into the proposed policy, and in June of this year, the OPTN Board of Directors will vote on this policy. If approved, it would be implemented sometime in the next year or two. We will round out this event with a Q&A panel, time permitting. Feel free to use the Q&A tab to ask questions, and we will address them during the panel at the end of the event. I would like to turn the mic over to our Executive Director, Melissa McQueen.
The Pediatric Heart Transplant Society is a multidisciplinary, professional, and collaborative organization dedicated to advancing the science and treatment of children through the journey of heart transplantation. PHTS is proud to partner with Transplant Families in organizing today's discussion about heart transplantation using ABO-incompatible donors, and we thank each other for this collaborative effort. Transplant Families is here to serve pediatric transplant families and the unique challenges and celebrations they experience in their journey. They provide support, education, and hope to pediatric transplant families everywhere. We welcome you to join us and check out all our programs at transplantfamilies.org. And finally, also be sure to join us at the end of April for our annual Pediatric Transplant Conference. We have welcomed pediatric transplant clinicians to submit session ideas, and we are happy to say that they have been very generous in their responses. In years past, we have covered innovations in heart, kidney, and liver sessions, psychosocial sessions that cover topics ranging from how to talk to your school about your child's transplant, to transitioning from teen care to adult care, and learning about activities that you can do with your child. We had a whole bunch of kids sessions that they were able to participate in gaming and connecting with other groups of kids through transplant camps and other programs. Registration opens next week. You can register via our Zoom portal or our website at transplantfamilies.org and specifically /PTC 2023. Joseph, thank you so much, and I will give it to you.
We're fortunate to have three esteemed presenters this evening, all of whom have leading roles in pediatric cardiology and heart transplantation research. Organ transplant parents everywhere have benefited from the leadership provided by these practitioners. Dr. Ann Dipchand is professor of pediatrics at the University of Toronto and a pediatric cardiologist and the head of the heart transplant program at the Hospital for Sick Children, or SickKids, in Toronto. Her clinical research activities are focused on pediatric heart failure and transplantation. Dr. Dipchand is the past president of the International Pediatric Transplant Association, or IPTA, and has been involved in multiple leadership positions in other organizations, including the American Society of Transplantation, where she is currently on the board of directors, the International Heart and Lung Transplantation Society, the American Heart Association, the Canadian Cardiac Transplant Network, the Canadian Society of Transplantation, and many others. Dr. Dipchand was the founding president and CEO of the Pediatric Heart Transplant Society Foundation, a not-for-profit foundation dedicated to advancing the science and treatment of children with end-stage heart failure listed for or following a heart transplant. She also actively spearheads opportunities for children and families of children with organ transplantation, including educational symposia and written educational materials. Dr. Simon Urschel is a pediatric cardiologist and immunologist and director of the Pediatric Heart Transplant Program at Stollery Children's Hospital, providing heart transplantation for all Western Canadian provinces and territories, and associate professor at the University of Alberta. He received his training in pediatrics, congenital and acquired immunodeficiencies, and pediatric cardiology at the Ludwig Maximilians University in Munich, Germany. Dr. Urschel's research focuses on the immature immune system of early childhood and how natural weaknesses of the immune system can improve outcomes of organ transplantation. His work on blood groups, incompatible heart transplantation, and desensitization therapies has contributed to establish this technique as a standard option in many parts of the world, resulting in shorter wait times, better use of donor organs, and improved survival after heart transplantation. Dr. Urschel serves in many leadership roles on international, national, provincial, and local organizations, including the International Society for Heart and Lung Transplantation, the Pediatric Heart Transplant Society, the Canadian Donation and Transplant Research Program, and ATI Transplant Services Alberta. Dr. Brian Feingold is Medical Director of the Heart Failure and Transplant Programs at UPMC Children's Hospital of Pittsburgh and a Professor of Pediatrics and Clinical Translational Research at the University of Pittsburgh. He has nearly 2 decades of experience in outpatient and inpatient management of heart failure, pulmonary hypertension, and pre- and post-transplant care. Dr. Feingold's research and quality improvement interests include improving heart failure inpatient care, cardiac involvement and outcomes in Barth syndrome, care of the allosensitized transplant candidate, and clinical use of non-invasive assessment of rejection after heart transplantation. Dr. Feingold is the immediate past chair of the Pediatric Heart Failure and Transplantation Subcommittee of the American Heart Association and a member of the OPTN Pediatric Committee. I would also like to note that Dr. Feingold developed the original policy proposal, though many others have subsequently been involved in its development. With all of that out of the way, we will begin with the presentation by Drs. Dipchand and Urschel.
Excellent. So thank you for the invitation to present here today on something that I'm very passionate about, and I want to simplify the title into why, how, and how far for ABO-incompatible transplantation. And I want to introduce you into why would you even consider an ABO-incompatible heart transplant? What is the specifics of the immature child responding to HLA and ABO that allows ABO-incompatible transplant? What did we discover on our way learning about this type of transplantation? What are the boundaries and limits currently recognized? And where may we be going from here? So the why is pretty obvious if you look at the sheer numbers of a large population of very young children in the first and second year of life that need a heart transplant. And at the same time, at this huge burden for this population to not survive to transplantation. So this is data from the US, a little bit older, but very similar in many places. And about 25% of the babies will not survive to transplantation. And at the time in the 90s, when ABO-incompatible transplantation came up in Canada, the mortality was around 50%. So only about half of the kids would live to transplant. There's also benefits of being naive or immature, because the immature immune system has to learn what is good and bad, same as everything else in the body. And some things that may look really scary may actually be not dangerous at all. Other things we may be able to deal with if we keep our distance or the right protection. And so the immune system learns to identify and defeat potential harm, while at the same time learning to differentiate and tolerate non-harmful interactions. And this actually finds its expression in the survival of infant heart transplants. So if you take the purple line here, you can see, yes, they have a high mortality early in life, early after transplant, but over time, actually, they accept the hearts much better than anybody later in life. And if you take that early death rate out, then you see that 25 years after this registry was started, more than half of the patients that had a baby heart transplant still had not reached still had their first graft without needing a retransplant and living with it. Now, why can't we just transplant any organ into anybody? The biggest difference between you and me is the human leukocyte antigen, HLA. You will often have heard about that. And it's a protein structure on the surface of cells. And it's basically a passport that the cell uses to show it belongs into that body, but also it is not altered, for example, by viruses or tumors. And I've put this picture on here because it's the first successful kidney transplant between the donor and recipient. And as you notice, they're identical twins, which is the only situation ever in which you have completely identical HLA and need no special precautions to transfer an organ. But obviously, it's not a given situation, and particularly not for heart transplantation. If we get a foreign human material into our body, then we respond with forming antibodies. And this is a study that has looked into how early can this happen and has assessed infants that got a homograft, so a Norwood surgery for reconstruction of the vessels in a hypoplastic left heart syndrome. And 80% of those kids that got something repaired with a homograft in the first week of life actually were able to fight that with antibodies. So it's something that is there and ready as we get born. How does it work? I'm not going to quiz you about that afterwards. It's really just to show you how kind of in principle the cells work together. So we have antigen presenting cells. We have T cells, which are basically the officers of the immune system, who then direct the cells to fight a certain cell or type that is infected or foreign, and also activate B cells that have bound the same antigen to produce antibodies against this. This works for proteins, but you cannot fit a sugar into this process. And that's where the blood groups come into play. So the ABO blood group system has been invented by this stern-looking gentleman from Austria called Karl Landsteiner, who basically bled all of his colleagues and then mixed the blood cells of one person with the plasma of another. And he found some of them would agglutinate the red blood cells of some, and he would name them A or B, and some of them wouldn't agglutinate anybody's red blood cells, and so he would name them 0 or O in the now English way of talking about it. And he published that in 1901 to 1903 and got a Nobel Prize for it in 1930. In the meantime, we have learned how these blood groups are formed, and they all have the same backbone. And the key thing about it is they're sugars, they're polysaccharides, they're not proteins. And they're not very different, actually. It's just some little extras that make you A, B, or AB. They are not only on red blood cells, but they are on most cells of the tissue, or on many cells of the tissue, and that includes actually the endothelium of cardiac vascular system, which is basically the skin on the inside of the vessels. We develop antibodies against our non-self blood group automatically. We don't need to have any blood transfusion or any human tissue. We develop that probably in response to intestinal bacteria that have similar sugars on their surface. So we don't need to have any contact with that. Why is that again important? Because these sugars, as I mentioned, cannot use the normal pathway of activating the B cells, but the B cells actually bind to these sugars and then cross-activate each other, and that way produce antibodies earlier and more immature type of antibodies. And this gets enhanced by what's called the innate immune system, so the complement system, other ways that can help with the activation of these B cells without needing a T cell signal. Why is that important? Because clinically for a long time, we noticed that if bacteria are encapsulated in sugars, they evade the immune system in the very young age. So this is almost historical picture of something called epiglottitis, which is a pussy infection of the throat that actually cost a lot of children their lives in the up to the 1980s. Similar, we have pneumococcs that cause pneumonia and meningococcs that cause meningitis, and all of those are much more aggressive in young age. So people started trying to vaccinate the young children with those polysaccharide vaccines, and it turned out they did not work. They did not help at all, until some brilliant people came up with the idea that you could connect these sugars to a protein, and that way make the T cell respond to the protein part, while the B cell that has bound the sugar part also gets activated. And for the first time, it was possible to get young children vaccinated against sugars and get them to respond properly against it. And this is very nicely illustrated in the history of this Haemophilus influenza type B throat infection. As you can see here in the 80s, as I mentioned, it was a very feared infection leading to the death of many children. And when they tried sugar vaccines, nothing really changed. And once they used the combined vaccines, that's basically disappeared. And when I talk now to our pediatrics trainees about it, they have no idea what I'm talking about. So this is Dr. Laurie West, and she caught a big fish knowing about these things, because she thought if the children don't respond properly to these sugar capsules, maybe they also won't respond properly to the sugar surfaces on the heart. And it may be safe to give them a heart that is not of the same blood group. Until then, it was an absolute dogma that you could never use a foreign blood group and cross that. But that was all information that came out of the adults. And when they crossed the first 10, used the first 10 patients and crossed that barrier, they found actually that it worked very well. They had, at the time, done a 2 to 3-fold blood exchange. They had 2 patients passing away in the first year and 1 needing an early retransplant. But overall, they had a survival of 80% at 5 years, and they did not think that any of those deaths were actually associated to the blood group rejection. And they were able to reduce the waitlist mortality from 58 to 7% at that time. The most exciting thing, however, they found is, this is what I told you earlier. So every healthy person usually will come up with the antibodies against their non-self blood group by about 2 years at latest. But these kids that had gotten the ABO-incompatible hearts showed something different. If a blood group O recipient got an A heart, they would not develop antibodies against A. If they got a B or AB heart, they would not develop antibodies against B. And this actually turned out to be true much longer than infancy. So we have done this study where we pooled the data from Canada, Germany, England, and the US, some pioneer centers in the US a few years ago, and we found that up to 8 years after transplant, still these patients would not have significant titers against the blood group that they were transplanted again, while against the other blood group that they didn't have a heart in their body with, they would just develop normal antibodies. The other thing we learned from this collaborative study was that you actually didn't have to be more aggressive with your immune suppression to achieve this tolerance. So they would get the same induction that people would usually do with either ATG or basiliximab. Some even had no induction. They would get their usual tacrolimus and mycophenolate and a steroid in the beginning, and then later on, just typically a dual combination of tacrolimus and mycophenolate at the time, and would do just fine with that in the long term. From an immunological perspective, we learned that the cells, the so-called memory B cells with IgM expression, seem to be the key cells responding to the blood groups, and they are very few in early childhood. By 5, 6, maybe sometimes up to 10 years, they will reach the numbers that we have in adult life. Interestingly, the children that had received the ABO-incompatible heart transplant developed their immune system differently. So they would not come up with as many of those specific cells, but would have a little bit of a different immune response. So we were curious how that affects their outcomes, and looked into how do they overall do with their organs. And one of the big surprises we experienced, because we thought, oh yeah, there's more that's foreign, so maybe they're more aggressive about the heart, but we found the opposite was true. And those kids that had ABO-incompatible transplants had significantly fewer antibodies against HLA and none against the HLA epitopes on the donor organ. And this was meantime confirmed by other studies, one out of Seattle, for example. And what is the clinical outcome? So we're lucky to have the Pediatric Heart Transplant Society that collects the data of many, many children, and we're able to compare 364 children versus 1,800 that had received the ABO-compatible transplant, all within the first 2 years of life. And as you see, those lines are all parallel, so they had the same survival, the same likelihood of getting graft vasculopathy, the same likelihood of getting PTLD or cancer. So no difference here in outcomes. But surprisingly, the red group here, the ABO-compatible children, had a higher rate of rejection and had a higher rate of infections than the ones that got an incompatible heart. So that came again as a bit of a surprise, because we were of course worried when their immune system changes, they may be more vulnerable to other bacteria. But even if we look at the encapsulated bacteria that are specifically targeted by the immune system that is not as active in those children, they had fewer infections with those than the ones receiving a compatible heart. And based on that, in Edmonton, just as an example, we have liberalized our approach quite a bit. So at present, we would list every child that is up to 2 years old and has a titer of 1 in 32 or less automatically for ABO-incompatible transplant. They go beyond these limits, then we have a discussion, and sometimes we may still list them. Sometimes we may decide to not go that pathway. We don't do any more antibody removal in the OR up to a titer of 116, which is much less stressful for the body for the children when they get their transplant. We use ATG induction only for patients with higher titers and otherwise baseliximab. And we do exactly the same immune suppression and surveillance, so no extra biopsies, nothing else than what we would do, except for looking for the isoglutenin titers, obviously, after the transplantation. Now, the big question is, how far can we go with that? As I mentioned, the first reports of accidental ABO-incompatible transplant in adults were always with a terrible outcome, and accordingly, there was this dogma that you could never do it. However, an interesting study recently looked into what happened actually to those adult patients that accidentally got an ABO-incompatible heart, and found that while, yes, a third of them would die in the first year, once they were beyond that, they had similar survival to those receiving a compatible heart. And that suggests that if you would do the right measures, you may be able actually to even do this in adults. And in fact, that has been done in 2 selected patients in Sweden, where they treated them and then gave them intentionally an ABO-incompatible heart. We locally have done it up to 6 years old. The Newcastle group has reported up to 9-year-old patients receiving ABO-incompatible transplant, and it's just from our paper using the PHTS data. It's only 27 children older than 2 that are in this giant database that have received the ABO-incompatible heart, but as you see, their outcomes are no different. It's a small group. I wouldn't want to conclude anything from that, but it's an interesting observation. Now, where are our limits? This is again Karl Landsteiner and how he used to do titer determination in 1901 by just basically taking a little bit of blood and mixing it 1 to 1, 1 to 2, 1 to 4, and see how long it takes until we see no more clogging of the blood. And this is how it's being done in 2023, exactly the same. So 120 years later, we still use the same technique, and that's what we base our clinical decisions on. The other thing is, not all of those antibodies against red blood cells may also harm the heart. So some of them may bind the red blood cells, but not the heart. So it's not a perfect technique. And if I send the same blood to different labs, then I get quite variable numbers. And even if all of those labs use exactly the same protocol and technique, there is still a difference that may make my 1 in 4 a 1 in 32 in a different place and a 1 in 1 in a different place again, which gives us a little bit of uncertainty there. So new techniques, including some that Dr. West's lab is working on, use, for example, the HLA detecting platform and try to standardize that and have a better way of comparing what happens in other places to what happened here. We can also offer immune profiling. So if we have older kids, we can see, do they have these memory cells? Do they have a response that is already similar to that we would expect in adults? And finally, the big question is, what happens if we manipulate the B cells? If we just destroy them, for example, for HLA sensitization, as some of your centers may do as well. And we have recently done that in a 6-year-old where we treated for HLA antibodies, and then the A antibodies came down as well. And eventually we transplanted her at the age of 6 with an incompatible heart, and she's now 3 years past that, doing perfectly well with no antibodies. So that's all I had to say. And as you can see, this is kind of where we are with ABO-incompatible transplantation. So we see that there must be some trees underneath here, but we don't know all of the details yet. And hopefully we'll make more progress and learn more about it. So thank you for listening.
All right. Well, I really like to thank Transplant Families and PHTS for including me in this webinar today. I'm going to talk about the clinical outcomes of ABO-incompatible heart transplantation from the initial experience to the present. I also want to take the opportunity to thank all of the families that trust us to take care of their children and to allow us to include them in this important research, like the studies that I'm going to share with you, so that we can help your children and hopefully many, many more. So let's start with the initial experience. As you heard from Dr. Urschel, we had the idea, but we weren't really sure what was going to happen. And the initial experience was published in 2001, over 20 years ago, with the first 10 infants transplanted. And the most important thing to remember is that we didn't see any hyperacute or severe rejection or death related to using a different blood group in any of the patients. Very quickly, there were no other adverse clinical effects, no increased rejection of any kind, no increased drug side effects. And one of the most important things was that our infant waiting list mortality here at SickKids, which is the chance of dying on the waiting list, went from over 50% to less than 10%. So what we concluded from that was that ABO-incompatible heart transplantation can be safely performed in the infant population. The next logical question, of course, would be, what would happen when other centers tried to do the same thing? We won't go through all of these, but it's just to show and explain that multiple other centers began to report their experience in the first half of the 2000s, with the largest coming from the UK of 21 patients, and they all had similar clinical experiences and similar outcomes. The first report from the UNOS database consisted of 35 ABO-incompatible transplants done before 2006, which was only 6% of all the infants listed in the United States over that time period. What we learned from that was that people waited until the babies were much sicker before they listed them for ABO-incompatible heart transplants. And at the same time, the infant waiting list mortality was still over 25%. So with all of these smaller experiences, we learned that we can do ABO-incompatible heart transplant. But the next question became, does ABO-incompatible transplantation equal ABO-compatible transplantation? I do remember at the time talking to my American colleagues, and this was one of their biggest hesitations to expanding the use of ABO-incompatible transplantation. What if in the longer term the patients didn't do as well? So we set out to answer that question, and in 2009, we did report our ongoing experience with over 10 years, comparing 35 ABO-incompatible and 45 ABO-compatible patients from the same center here at SickKids. Now, in these graphs, the red lines are the compatible patients and the blue lines are the incompatible patients, and we do statistical tests to see if there's any difference. The important thing here was that the ABO-incompatible patients were equivalent to the ABO-compatible ones in our experience, and there was no difference in rejection, kidney disease, or coronary artery disease. But most importantly, the survival was the same out to 10 years post-transplant. And that is what people really wanted to know from us. There was also no difference in survival from that UNOS cohort that I talked about. So those 35 patients out for 3 years. And then there's 85 patients in the PHTS database followed out for a year that showed no difference for rejection, infection, cancer, and survival. So then we have multiple publications showing us that there were equivalent outcomes for these ABO-incompatible patients to help us make decisions about moving forward with this kind of care. Most recently, Dr. Urschel and I were involved in this study, which he has summarized for you, of the largest group of ABO-incompatible patients, also showing similar outcomes and less rejection and less certain infections, which is very intriguing. So now we have 2 thumbs up with equal clinical outcomes and multiple reports that advocate for listing all infants to receive the first appropriate donor organ, regardless of the donor blood group. But did it make any difference to the children on the waiting list for a heart transplant? What do we know about that information? Well, as I indicated in that very, very first study, our one center decreased our infant waiting list mortality from over 50% at that time to just under 10%. We then did an analysis to look at 95 infants listed that way. And what we learned was that a strategy to accept ABO-incompatible hearts significantly improved the likelihood of transplantation and reduced the waiting list mortality, but it didn't adversely affect the outcomes. So that's really important. So then we looked to the UNOS database again, and in the first half of that time period, we see that there were 27% of the patients listed for ABO-incompatible transplants, but only 20% of all babies eligible received an ABO-incompatible donor heart. And although the patients had a shorter waiting time, the waitlist mortality didn't improve. That particular group of authors made the observation that despite the intended merit of ABO-incompatible listing, it had not yielded lower waitlist mortality in the US under the UNOS allocation algorithm at that time. And they also noted that consideration should be given to altering the allocation system in hopes of improving organ use and reducing waitlist mortality. A little bit later that decade, we see another analysis where 17.7% of babies were originally listed for ABO-incompatible, but by 2007 was over 50%. So that's great because people are actually moving forward and listing their babies for ABO-incompatible. In this same analysis, though, we were still seeing that it was sicker children that were listed. And again, there was no difference in the waitlist mortality, but on a positive note, certain babies were doing better. Babies with blood group O, there was a reduced waiting list time, and there was a reduced waiting list time overall. So we can slowly see as we move forward in time that there is being a difference made using ABO-incompatible listing strategies. But they did conclude that ABO-incompatible heart transplant was underused in many US centers, and they said a finite quantity of infant donor hearts were still being discarded every year in the US, and there was data to support this statement. They also felt that some waitlist deaths could be prevented by expanding the practice of ABO-incompatible listing, because at the time, 30 to 40 infants were dying annually in the US waiting. The most recent PHTS analysis actually gives us some good news. So in this one, the ABO-incompatible listing increased from 49% to 72% in 2017, which is telling us that ABO-incompatible listing has become much more routine for children less than 2 years of age. The ABO-incompatible children were still sicker, but they had similar survival. So that's also very encouraging. And again, in the red line, there was a shorter waiting list time for these babies. So I just want to end with one comment for the future, which you also heard from Dr. Urschel. And that comment is that we really don't know yet what the upper age limit is for ABO-incompatible heart transplant, and that remains to be determined. Thank you for your attention, and I look forward to answering any of your questions a little bit later.
Thank you, Drs. Dipchand and Urschel, for that wonderful background information. We'll now go to Dr. Feingold for the policy segment directly relating to the proposed OPT and UNOS policy changes.
Great. Apologies again. So thank you to Dr. Urschel and Dr. Dipchand. It's always a pleasure to listen to you guys speak about this topic because I always learn something when I listen to you both. So I'm going to speak a little bit about the OPTN policy proposal that is now in public comment phase. And this is regarding, there's a number of proposals, and I encourage you to to go to the website for OPTN and look at them all, but we're going to talk specifically, obviously, about the ABO-incompatible heart, lung, and heart-lung transplantation proposal. So this is what that website looks like if you've not been there before. It says OPTN, and I have a little screen break here, but if you scroll down, you'll see modify heart policy for intended ABO incompatible blood type offers to pediatric candidates, and you can just click here to provide feedback, or you could actually click on the policy here, and it'll take you to this screen where, again, you could provide feedback. And I think that that is important, that individuals, after hearing this webinar or reading and considering this or talking with their providers, perhaps do provide feedback. You can read the proposal by clicking here, or you could read what comments have been already offered. And there's an overview here on this webpage of the policy and a brief video that you can watch showing some details of the policy by one of the other developers of the policy, Dr. Daly. The policy revision intent is to expand access to ABO-incompatible heart transplantation. The obvious group to whom this would apply are individuals who have previously received an ABO-incompatible transplant, for the reasons being that you heard in the earlier talks, that we know that there's good data now out to many years after transplant. When you receive an ABO-incompatible organ, that you actually will not develop the antibody that would recognize that incompatible blood group antigen, that blood group marker. And so it would seem like a no-brainer that those individuals, should they need a second transplant, should be eligible for an incompatible transplant with that same blood group at the very least. But there may be others who also would benefit from receiving an ABO-incompatible transplant, either because they might receive it more quickly, or because, as Dr. Dipchand said at the end of her talk, we don't really know the upper limit of age at which this can really be done safely and successfully. And in the US, without getting too detailed, we have had limitations in our allowances from current policy that we have really been restricted and not been able to list anybody over age 2 for an ABO-incompatible heart transplant. And there are likewise very few individuals who are above age 2 who have received an ABO-incompatible heart transplant in the US. This is in contrast to Canada and the United Kingdom, where their listing policies and allocation allow for transplantation at older ages, above age 2, with an ABO-incompatible heart. And Dr. Urschel's slides made reference of the fact that they will list older individuals than we are able to list in the US, and will list individuals with titers. So titers, a reflection of how much antibody is present. The higher the titer, the more antibody present. And it sounds like, will not even be too worried about a titer of 1:16, which is a titer at which our current proposed policy will sort of be the upper limit of allowance. So I'm going to jump a little bit to the policy details and trying to keep it relatively simple, because it can be a difficult or challenging topic to go through. But currently, you must be listed in the US prior to age 2 for an ABO-incompatible heart, whereas in the proposed policy that is out for public comment, this gets expanded to being listed prior to age 18 for a heart. In addition, the current policies in the US allow for listing for heart or lung transplantation for ABO-incompatible, whereas the proposed policy would be clear to make this clear for heart, lung, or heart-lung transplantation. And heart-lung transplantation as an entity is not very common, but it's important that the policy be consistent across these organs because individuals may receive either a heart or a lung, or potentially both. The other significant change is that currently only individuals listed at the highest urgency status, 1A, or the second highest urgency status, 1B, can receive and can be listed for an ABO-incompatible heart, whereas in the proposed policy that's being commented upon publicly, that's being expanded to all listing statuses for heart. And I believe there are no restrictions either for lungs. Lungs use a different mode of denoting urgency, and it's currently a lung allocation score, and I believe that's moving to a slightly different score in the next few weeks. But regardless, I believe that there are no limitations in the proposed policy with respect to lung for urgency. So some of the things that have not changed with respect to these policies. So under age 1, any amount of antibody, regardless of the amount of antibody you have, you can be listed and receive an ABO-incompatible heart transplantation. Above age 1, and currently to anybody listed prior to age 2, but expanding to anybody listed to under age 18, this will be restricted to a titer of 1:16 or less. And currently, and in the new policy, the titer, that blood sample that tells us how much antibody is present against the other blood groups, has to be repeated every 30 days and reported in the listing system in the US every 30 days. There is some delineation between what we call primary or secondary designation for an ABO-incompatible heart transplant, and that is not changing, meaning under age 1, the recipient's blood group does not affect organ allocation, considering weight, height, urgency status, and distance. So those are things that will always impact whether an organ might be allocated to one individual or another. So I give families the example, if there's an organ available in California, it is unlikely to come to us here in Pittsburgh because that distance is too far. So those considerations stay in place. You would not take an adult size organ and give that to an infant. You would not take an infant and put that in an adult. So weight and size stay in place. And allocation with respect to urgency, if somebody is in the 1A group, they are in general likely to have access to an organ sooner than somebody in the 1B group, and that person sooner than somebody in the group 2, the status 2. But all those things being considered, now blood group no longer will matter, blood group no longer matters under age 1. Over age 1, there is a slight preference for an ABO compatible transplant versus an incompatible transplant. And I can show here, this is a schematic, or this is a representation of a table that's in current policy that shows that, for instance, for a given organ, first it would get allocated to a pediatric candidate at the highest listing status, 1A, within 500 miles of the donor, who has if you're over age 1, who is a primary blood type match, which would be essentially a compatible transplant, and then secondarily would go to the incompatible listed individual. And then likewise, when you get to the next stratification, again, it would be primary and then secondary, and they follow each other one after another. And so above age 1, there is this slight preference still preserved in the policy to go to an ABO compatible recipient, but it now allows for ABO incompatible transplantation up to age 18, where again, current policy allows only for individuals listed prior to turning age 18, whereas current policy allows only for individuals listed prior to age 2 to receive and with tighter requirements. So I think some of the considerations with this policy. So again, it allows for ABO-incompatible heart-lung or heart-lung transplantation for anyone, any status 1A, status 1B, status 2, who is listed prior to age 18 years and continues to have a titer under 1:16. Under age 1, there's no titer requirement. It does not allow for ABO-incompatible heart-lung and heart-lung transplantation if you are listed over age 18 or over, or with a titer that is above 1:16. The next titer would be 1:32 or above that. And it does not, but it does not specify that individuals with a titer of 1:32 or higher could not repeat their testing and see if they can obtain a titer of 1:16 or lower. but it does require that titers are repeated every 30 days and reported in the system every 30 days to maintain that listing status. So with those considerations, I think there are some natural questions that should be asked by the community as this policy is considered. One, should status 2 candidates be eligible for an ABO-incompatible heart transplant? I think you could make an argument that these are less ill candidates and maybe they shouldn't be, but I think you can also very well make an argument that this seems to be safe when done in the appropriate way, and we shouldn't restrict it if good use of those organs will be made and these individuals may be able to achieve transplantation with them. Secondly, should there be a titer requirement to report to UNOS, to report to OPTN or UNOS every 30 days? And if there shouldn't be this reporting every 30 days, should it be less often? Should it be every 3 months or 6 months, or should it be never at listing? Generally, individuals right now who are listed for ABO-incompatible transplantation, though not exclusively, tend to be listed and tend to stay in the hospital. And so these are labs that can be repeated every 30 days pretty easily. But if we're now talking about expanding this to candidates who are status 2, those are generally individuals who are out of the hospital, who are not staying in the hospital to await a transplant. And it may not make sense to repeat this periodically. And then thirdly, the policy does stipulate that, in fact, an individual cannot have received therapies to lower their antibody titer. So you can't have some therapy that would lower your titer and then draw your titer and then say, oh, look, I'm 1 to 4, now I can be listed. But it doesn't actually specify what those therapies are. And then I think another question would be to ask, well, why does it really matter if somebody received an antibody reduction therapy in the last 30 days? If they have a low titer and you can ensure that they maintain a low titer that puts them at low risk for rejecting that organ early on and maybe even post-transplant, then why should we even care whether somebody gets some treatment to lower their titer? And then lastly, it's possible that somebody could get a treatment more than 30 days prior to their blood sample that keeps their titer low for 3 months. And so there's a bit of a loophole that develops with this 30-day criteria. And so that's something else that we should consider, I think, as we think about this policy and public comment. So that's really all I had. I would be happy to answer questions, or I don't know how you all want to handle it from here.
So if we could ask the presenters, we have just a few minutes, but there are a couple questions. So if the panelists could please turn their cameras on, that's okay. And so I'll read the 2 questions, and then I think we have a couple that were sent in. So the first one is from Lourdes Matamoros, and I apologize if I did not get your name correct. She asked, why is ABO-incompatible prioritized over ABO-compatible? I think the question was meant to be the other way around, ABO-compatible prioritized over ABO-incompatible. So I'll leave that to the group.
I can speak from the policy development standpoint, I guess, a little bit, which is that I think we felt, without divulging too much inside sort of comments, and I'll be honest, this policy took a long time to develop, and I think represents an amalgamation of people's input with respect to how to handle this. I think the community wanted to move safely. And just as Dr. Dipchand alluded to, we don't know that upper age limit, but we also don't know that upper age limit. And so rather than just allowing this at every age up to age 18 and in every circumstance, it seemed like the policy developed in a way that we were trying to be not overly aggressive, but to further expand the use of ABO-incompatible transplantation.
Okay, we have another question from Sandeep Sainathan, and the question is survival similar for ABO-incompatible and ABO-compatible irrespective of the primary diagnosis, congenital versus cardiomyopathy? Any difference in patients with a failed cardiac surgical procedure? I think this is a question that really would concern parents, but I think many aren't aware of the implications here. So Dr. Dipchand, I think you were prepared to answer.
Sure. In terms of the actual answer to the first part of the question, ABO-incompatible versus compatible, yeah, there is no survival difference based on congenital versus cardiomyopathy diagnoses. Obviously, I couldn't go through all of those details in this presentation, but we've done that analysis multiple times, and diagnosis is always factored into the analyses so all of those graphs that I showed you is shows you that there's no difference. There's a little subtlety in the second part of your question, any difference in patients with a failed cardiac surgical procedure. As Dr. Feingold alluded to, there's many other things that go into allocation, and there's many other things that go into outcome. So there's definitely a survival difference for patients who've had failed cardiac surgical procedures, and also for patients with a congenital diagnosis, but it's not been shown to be related to ABO incompatibility.
Maybe I can add a little bit to that. So, I mean, obviously, there is a higher proportion of children with congenital heart disease in the ABO incompatibles if we take the whole population, just because they're typically younger and they're, as we've heard there in the past, have been the sicker ones. I have to say from our experience, and I'm sure Dr. Dipchand will mirror that, I don't see a reason why we would give a secondary allocation at all. Like the blood group doesn't really matter to us as long as they are in the fitting window, and all the data we've generated so far, we've observed is that despite them having been a sicker population, they do equally well. So I don't think there's a good argument to say we should preferentially allocate a ABO compatible over an incompatible. In fact, we may actually disadvantage the recipients of an ABO incompatible organ that way, because we first look, if we only give them the ones that we don't think were good enough to be for a compatible organ and allocation, there is for sure a risk that we would disadvantage them.
We have another question from Catherine Thierry. She asks, if the patient received an ABO-incompatible heart as an infant and is now an adult, is it possible to receive another ABO-incompatible heart when they're over the age of 18?
So that's a really good, I was going to say that's a really good question. I'll speak to the under 18. It's not common to need retransplant under 18, but we have had to relist at least 2 that I can think of out of 300 plus transplants, and we have listed them for both blood groups, their original blood group and the blood group that they received an original donor heart from. Our adult program has asked us that, and they have relisted in the past. There's definitely a level of discomfort from a clinical perspective, but you can do it in Canada. I think what Brian's going to need to weigh in on is the fact in the American allocation system, you can't actually list them for an ABO incompatible.
Yes. So, Anne, you're absolutely correct. So currently, if you are over age 2 and you cannot list somebody for an ABO incompatible transplant, even if they previously received an ABO incompatible heart transplant under age 2. The new proposal, the policy that's being considered for approval, will expand that to if anybody who is listed prior to age 18, but to answer the specific question, which was, I think, above age 18, this new proposal will not still allow for that in the United States.
You're still a bit away from that because your patient, it hasn't been done that long. But as Anne says, it's reality here. So we have young adults that are 23, 25 years old now and may sometimes reach it. I have a very interesting anecdote, although a sad one, to contribute to that. One of the very first patients actually decided that she didn't want to take her medications anymore. And she went into rejection several times, all based on HLA antibodies, and was not retransplanted. Interestingly, her anti-A antibodies, which was her donor blood group, never came up through that whole process. So there's really no good reason to assume that you couldn't retransplant with another ABO incompatible, and 18 is obviously not a magic number that changes anything about that. But it's very little known. We have one that we retransplanted with an incompatible and one with a compatible organ secondarily, and there's one publication from Munich that has a compatible retransplantation of the incompatible heart, but has shown that even 3 years after that, the anti-A antibodies were still not back, despite the heart having been replaced. So yeah, I think that's a good thing to consider as well. The one thing, if I may, about the policy I found interesting is that they just automatically include heart, lung, and lung, although the information density of data there is much slimmer. There's much fewer ABO incompatible lung transplants. So I found that interesting that they're pretty bold, which I think still obviously the centers will decide whether they want to go that pathway, but yeah.
Yeah. So sorry, just to add, development of policy is, as I said, an amalgamation of input from others, and so you don't always get what you want. But I think that this is moving the needle in the direction that we want to move it in the U.S., and I'm optimistic that should this policy be adopted or something similar to what's being proposed be adopted with added experience and then more data showing that, listing and retransplantation at older ages prior to age 18 is safe, that might help move the needle. But yes, I would agree with you scientifically or with what we know that, it would seem like if somebody has low isohemagglutinin, low anti-A or B titer respectively, as a 30-year-old, biologically, I would still think that individual would safely, would do well with retransplant with an ABO incompatible organ at that age.
So with that said, that's all of our questions for today. So we're going to close out this session.
Joseph, can I make one more comment real quickly?
Sure, go ahead.
Yep. Again, this is a policy that has not been adopted. This is a policy that is in public comment. People have raised good points about this policy. I think it would behoove folks to think about this policy and ask these questions in the public comment. I'm in favor of this, but I wonder about this, or I'm in favor of this. This is great, or I don't like any of it. Don't do it. Whatever you think. This is your opportunity to provide feedback. This is how the community, will see that feedback and respond to it. And if there's enough feedback for certain things, then it's my understanding that the policy could still be adjusted or tweaked. So please think about that with all of these policies, not just with this one. Obviously, this is the one we're highlighting, but there's policies always in public comment at all times of the year, at least in the US. So I implore people to please look at that who have an interest in that realm.
So with that said, we hope that you all find today's session to be of help to you, whatever stage of the transplant journey you're on, or if you're a provider that it informs your public comment that you and we ask families to provide public comment too. We know there will be a lot who couldn't make it live tonight, who will be watching the recording that we'll be posting shortly. And the recording will be available on the Transplant Families YouTube channel. If you can see the links on the screen for our social media channels and our website. Thank you for joining us today, and we hope you have a wonderful evening.